So the first thing we will talk about is pyloric stenosis. Okay. This is very simple problem. Okay. But they usually will ask you questions. They're not going to ask you about pyloric stenosis. Most of the time, they will ask you about the pathology. So this is, if this is the GI tract, so this is your esophagus, the stomach come like that. Okay. And then you have the small bowel all the way going down. And this is the stomach. Okay. And this is the esophagus. The pylorus is right here. That is the first portion of the small bowel that take food from the stomach. And so it's very important. In kids, certain kids, there's stenosis. The muscle here is thicker. There's no blockage, okay? It's just the muscle is thicker than normal. And it acts like a valve, so it closes things up. That is all. That is the whole pathology. So there's a something we call hypertrophy. So you have hypertrophy of the pylorus. So it's thicker than normal. So it acts like the valve. So when the kid eat, food cannot go down. So based on the pathology, you can think about some of the signs and symptoms. You don't have to memorize it, but you can think about it. Usually it occurs like in the first child, firstborn baby. And they are usually boys. I don't know why, but the boys is always in trouble. So firstborn, and it's a boy. And so when the kid eat, the food doesn't go down. And what happened? The food stay. And then the kid will vomit. So they have this projectile vomit. It's not important, but just know that it's projectile vomit. This can go into like 3 feet because the food stayed there for a long time. And then the kid will vomit everything out. And it can go far away. And guess what? After they eat, they get hungry. So they're hungry again. They want to eat. So that's the signs and symptoms. The mommy doesn't know. The mommy would think probably this is normal. So after they eat, you eat all the food. Then a few hours later, vomit everything. Then you want to eat. And that's what keeps on happening and happening because nothing passed through the pylorus. And so you can figure out all the signs and symptoms the kid will be having. With this mass, you will feel it. But because the kids are very small, the pylorus is usually on the right side. It crosses over. So you see the stomach come down like that. The pyloric crosses over towards the right. So you feel a mass on the right side of the abdomen. Right. And so that's what usually you usually see in the test. I don't care about the shape, but you just have to know it, olive shaped. Because they will confuse you with intussusception. But it's very important to know that kids are very small, they're very skinny, and so you can palpate this mass on the right side of the stomach. And so that's why you see olive shapes, size, and it's on the right side. The kid is hungry all the time. There's a projectile vomiting, right? And so based on that, the other thing that will confuse you with is when you eat, okay, food in your stomach is gastric content, so it's white, it's food. The only time you see green stuff is in the small bowel, so in the bowel. So this is where you see green stuff. If the kid vomit, there will be no bowel, so it's non-bilious. So just be careful. This is where they trick you, non-bilious bowel movement, because it has emesis, because it has not get into the small bowel. So the emesis is non-bilious. So, and these are the things they will put on the test. And they want you to like answer them. Just pay attention that it's non-bilious emesis. And the kid is constant all the time, is vomiting all the time and won't eat. What do you think? The major problem, this is where they will ask you, is dehydration. If they're going to trick you, is they will send you into a dehydration pathway. So you already know what dehydration is. So if you see a question on pyloric stenosis, now they're asking me about dehydration, you shouldn't be surprised. And what is dehydration? If you get the lab work, you should see signs of dehydration. Their crate is going to be high. Okay, don't be surprised. Okay, their sodium initially is going to be low, but the body will compensate. Okay, their RBC is also going to be high. Don't be surprised, right? And then you can see their BUN and creatinine, both of them will be high because it's a sign of dehydration. All of them is high. And so they will try to give you these numbers and let you think they just want you to apply. So this is the application level of question where you have pyloric stenosis and they're asking you lab work, what do you expect? That is what you see. But the most important is what is going to happen when the kid vomit. And it's the same thing as somebody who has NG tube. You can use the same answer for somebody who has NG tube. When they vomit, it's the same thing. When they're vomiting acid. So they're losing H plus ion, right? So the H plus ion is lost, basically. So acid, they vomit acid. So everything that is coming out, they're losing H. So if you're losing H, what do you think is happening to your lab work? They're going to be metabolic alkalosis. So they will have metabolic alkalosis. If they're losing H plus ion, they're going to exchange it. The body want to compensate, and then what is in the stomach is mostly sodium. And then sodium, a lot of sodium, they're losing a lot of sodium. So they lose sodium too. So the body will decide that, hey, I cannot lose a lot of sodium. So they secrete aldosterone. So this is where aldosterone come in. And what aldosterone will come in for will lead to loss of potassium and then gain of your sodium so that you don't get dehydrated. So the classic lab work, as you can see, is they're going to have low sodium, right? Low chloride, and then metabolic alkalosis. So this is the lab work. Somebody who is vomiting is going to have hyponatremic, hypochloric, metabolic alkalosis, and hypokalemia. So, and that is the lab work. So you shouldn't forget this at all. Hyponatremic, hypochloric, hypokalemic, metabolic alkalosis. And then based on that, to treat them, it's just straightforward. Yeah, so treatment, you just give them their fluid back. So fluid, you just hydrate them. So hydrate the kid. And usually we prepare them, we hydrate them enough before surgery. They will need surgery to fix not the obstruction, but to open the muscle. It's the muscle that is thick, and it will open the muscle, and that will take care of it. And this is everything they want you to know about pyloric stenosis. They will start from here. The pathology that you have to know is there's olive shaped mass on the right side of the umbilicus. They vomit all the time. The vomit is non-bilious. They can turn into dehydration symptoms. So the signs and symptoms, you expect your mucous membrane to be dry. If it's a young kid, their anterior fontanelle, if you see that they see anterior fontanelle, it will be sucking. It will not be bulgy. It's not going to be thickened. It will be like really flat. So don't be surprised when you see that. And then the lab work you see is hypokalemic, hypochloremic, metabolic alkalosis. And that is all about pyloric stenosis. The other one they confuse you with is like intussusception, okay? Intussusception is just nothing than the same thing, the bowel coming, and this bowel is basically with telescope on itself. So it forms a telescope on itself. It's twisting. So the kid will have a twisting kind of bowel, and therefore you can figure out the symptoms. You have a bowel that is twisting. What is it going to happen? You're going to have pain. And the pain, because it twists and then it releases itself, it's back and forth. If you have you can try it. If you like a thread, you open it and you close it and open it. So the pain is going to be colicky. It's kind of colicky kind of pain. And then it releases itself. So the kid will be fine for a few minutes. All of a sudden they start crying again. Then they will stop. So these kids will cry and they are unconsolable. The mommy will try to do that, but they can't. So colicky, crampy, abdominal pain, right? In order to release the pain, think about it. When your belly is hurting, you always put yourself in the fetal position. So this kid, that's what they will do. They go into fetal position. That's how they draw their legs. They draw their legs up to their chest. So they draw legs up. And so if you see that in an answer choice, yeah, they draw the leg up to their body so that they don't, they will release the pain in their abdomen. So they are knee to the chest, basically, knee to chest position. It's because they want to relieve the pain. And they are unconsolable, like I said. And the pain is colicky. Those are the signs and symptoms of intussusception. Think about it. The bowel is being twisted. If you twist the bowel, it becomes ischemic. That means there's no blood flow, no blood going there. So the bowel becomes ischemic, and the bowel starts to die. When the bowel dies, it releases the mucus. That's the mucus you see with some blood. And the kid will poop. So that's the stool that comes out. And this is what they try to put in your test. You know, mucus mixed with stool is called a currant jelly stool. It's nothing than basically a description. They either will describe it a stool mixed with mucus, or they will write a currant jelly stool. It's because the bowel is dying. It's dying on and off. It's twisting back and forth. So it's the blood mixed with stool. And so think about it. For this patient, what do you think? You have a small bowel that it's twisting. It's no more the stomach or the pylorus. And I told you that there is bowel here in the small bowel. So here there is bowel here. So when the kid will vomit, this vomit is bilious. So this is a bilious emesis. And then, so if I'm setting a question, I will put this and I'll put it together with pyloric stenosis. And you can see pyloric stenosis, the emesis is not bilious, but for intussusception, emesis is bilious because it involves the small bowel. That's why they do that. The priority action for this is to diagnose it. So this is a priority action. You have to know that. Is to diagnose the problem. How do you do that? I mean, there's so many things, but the best way is to diagnose it and treat it at the same time. So diagnosis / treatment. So the treatment we do is we put air into the colon and then try to open it up. If you open, we know that the patient has intussusception. So you will see something we call air or pneumatic contrast enema, or they will use enema. It's the same thing. If they give you a contrast enema, don't choose it. If there's mnemonic there, you prefer air rather than contrast. But if they don't put mnemonic, then you can choose contrast enema. Is the same. Contrast enema doesn't treat it, it diagnoses it. But we want something that can diagnose it at the same time, treats the problem together. So you prefer mnemonic enema rather than contrast enema. Quick question. The therapeutic intervention. So if I treat this patient with pneumonic enema, what do you think is going to happen to them? That means I'm releasing the obstruction. There's no more twisting. Therefore, what should I expect? I should not expect no more current jelly stool. If you see that, that means the kid is still not relieved. So you have to be like worried. So if you see a question like that, that means you have not treated the kid. You have not relieved the obstruction either. So if you treat them, there should be no more current jelly stool. You should see normal brown stool, not stool mixed with mucus. That is a tricky one, but that is what you should expect. You expect no brown stool rather than current jelly stool still. Current jelly stool tells you there's still presence of intussusception. We don't want any more intussusception, right? So that's something that you have to pay attention when it asks you. So for this condition, know the pathology, and I intentionally left something out. I'm trying to see if you guys can catch it because it's very important. I don't like buzzwords, no buzzwords, like names associated with that. Because people pay attention to that and they forget the pathology. Remember, for the pyloric stenosis, we have a mass. The mass, the obstruction, it was on the right side of the, basically, of the umbilicus. This one is not olive shaped, but it's sausage shaped. So people basically pay attention to that and they forget the actual problem that the kid is having. So the mass that they will feel, the twisting of the bowel, it presents in the form of sausage. So if you see that, that's what it is. I don't like that, but they like giving it to you guys. So sausage shaped mass. But don't focus on it too much. A sausage shape is basically the bowel that is twisting, okay? And then for pyloric stenosis, it's just the thickening of the bowel, which is olive shape. So this is sausage shape mass associated with the intussusception. Okay, so that's the only thing. Pediatric, those are the two things you need to pay attention to. When you're reading, studying intussusception, you should look at pyloric stenosis because that's what they will confuse you. They will confuse you with. If I'm the examiner, that's what I will do. I will try and confuse you with that.